Good evening, everyone in India, and very good morning now from Australia. We've well ticked over into Sunday morning. We've spoken about the pre-op and operative concerns, so perhaps it's now time to talk a little bit about ancillary concerns during an operation. And to kick it off, we've got Anthony Bonavia from Hershey. Who better to talk to us about pulmonary pressures than an anesthetist and also a critical care physician? So over to you, Anthony.
Good afternoon. My name's Anthony Bonavia, and I'm an anesthesiologist and an intensivist at Penn State Hershey Medical Center in Pennsylvania, and I'm going to talk to you in 10 minutes about pulmonary pressures. So respiratory failure is not an insignificant issue following abdominal wall surgery and affects up to 1 in 5 patients, which is much higher than patients undergoing non-cardiac surgery. And so in 10 minutes, I'm going to talk to you briefly about pulmonary physiology that is relevant for abdominal surgery, specifically the effects of anesthesia and the effects of surgery on pulmonary physiology. So any discussion about pulmonary physiology has to start with a description of transpulmonary pressure. And this is basically the difference between airway pressure and pleural pressure. And airway pressure is usually approximated by the plateau pressure in mechanically ventilated patients, whereas pleural pressure is approximated by the esophageal pressure. Now, lung compliance is intrinsically linked to transpulmonary pressure and is zone dependent on the lung. And in the diagram there, you can see the lung compliance curve, which relates volume to transpulmonary pressure. And the slope of the curve, which is the change in volume over the change in transpulmonary pressure, is termed the compliance. The compliance of the lung is usually highest at the FRC, or functional residual capacity, where the slope is highest, and that forms at approximately the midpoint of the graph. Chest wall compliance is additive, and the total compliance of the pulmonary system is the sum of the inverse of lung compliance and chest wall compliance. Now, terms that are usually used are dynamic and static compliance. Static compliance is what we traditionally understand by compliance, and it's the relationship between volume and pressure of the lungs when there's no air movement, whereas dynamic compliance refers to compliance of the lungs when there's airflow into or out of the lungs. When we talked about dynamic compliance, what we're really talking about is the relationship with peak inspiratory pressure, whereas static compliance is the relationship with plateau pressure. And the graph here shows a mechanically ventilated volume-assisted breath. And you can see there's a difference between the peak inspiratory pressure and the plateau pressure. Now, what the peak inspiratory pressure tells you is the pressure needed to overcome both the airway resistance and to keep the lung distended, whereas the plateau pressure tells you the pressure that's needed just to keep the lung distended. And so the difference or delta refers to the airway resistance. Now, peak inspiratory and plateau pressures are most relevant when we're talking about volume breaths. In pressure modes of ventilation, the peak inspiratory pressure and the plateau pressure are approximately the same. Here we see 2 different volume breaths with 2 different issues. And the top of the graph, you see that there's a resistance issue because there's a big difference between the peak inspiratory pressure and the plateau pressure. Whereas in the bottom, which is usually more relevant for abdominal surgery, you have a compliance issue since both the peak and the plateau pressure are elevated. And I'll come back to this graph a little later. Now, when we talk about determining respiratory parameters for anesthesia, we usually take into consideration, at least conceptually, this hysteresis curve. And hysteresis is the term that's used to refer to the differences in lung compliance between inflation and deflation of the lung. And as you can see, it's a sigmoidal curve with upper and lower inflection points. And it's important to at least understand upper and lower inflection points because it helps delineate respiratory parameters, even if theoretical. So above the upper upper inflection point, or UIP, we get concerned about over distending the lung and causing barotrauma, whereas below the lower inflection point, we get concerned with what's called atelectotrauma, or trauma or inflammation caused by repeated opening and closing of the small airways. And so we overcome these problems by limiting our tidal volume to 6 to 8 mLs per kilo of ideal body weight to prevent barotrauma, and also using some degree of PEEP, which is above the lower inflection point, to prevent repeated collapse and opening of the smaller airways. The hysteresis curve, or the compliance curve, varies, and that's why it's important to know the baseline lung pathology of patient, because patients who have restrictive or obstructive lung disease have different compliance curves. So now I'm going to talk a little bit about the effect of anesthesia and surgery on pulmonary pressures. And the biggest effect of anesthesia on surgery is a drop in the functional residual capacity, which, as we mentioned, is the point of the greatest lung compliance. And the reason for this is manifold, but basically involves loss of muscle tone. Together with the loss of FRC, come a decrease in airway compliance and increase in airway resistance, especially of the lower airways. So much so that atelectasis develops and can affect up to 20% of the lung volume with induction of anesthesia alone, even prior to beginning the surgery. And this series of CAT scans illustrates that and shows that atelectasis correlates with shunt fraction and hypoxemia. At the very top, we have the CAT scan of an awake, healthy patient, and you see that there's no significant atelectasis. In the middle panel B, we see that there's some developing atelectasis, and this is the CAT scan of an anesthetized patient in which 0 PEEP is being used. And C shows the same lung after institution of 10 centimeters of water of PEEP and some recruitment maneuvers, and you see that the ventilation to perfusion matching improves, and the CT evidence of atelectasis disappears almost completely. There's other factors that contribute to atelectasis, including patient's BMI and fractional inspired oxygen, with a higher oxygen percentage contributing to atelectasis via absorption atelectasis. And so some of the maneuvers that we use both to decrease intraoperative hypoxemia and to minimize postoperative respiratory failure is to ensure that we have an analgesic plan that minimizes postoperative splinting by using PEEP. And I try to use a PEEP of at least 8 to 10 intraoperatively, since it's been repeatedly demonstrated to re-expand atelectasis, even though atelectasis rapidly reemerges after discontinuation of PEEP, meaning at extubation, which is why it's very important to pursue postoperative aggressive respiratory therapy, mobilize the patient, and minimize the use of abdominal binder if at all possible. If the patient's still intubated and you have severe issues with atelectasis, you can deliver what's called a sigh breath using airway pressures 30 to 40 centimeters of water. It's also very important, as I mentioned, to minimize the fraction of inspired oxygen during anesthetic induction, intraoperatively and postoperatively, and to minimize paralysis wherever that's possible. Now, what happens with abdominal closure and pulmonary function? So abdominal closure is usually associated with an increase in intra-abdominal volumes and concern for abdominal hypertension due to increased intra-abdominal pressures. Besides causing a loss in lung volumes, it also decreases chest wall compliance. And as we mentioned, chest wall compliance is additive. It increases peak and plateau airway pressures, as we already mentioned, and we'll mention in a couple of slides. And this is manifest clinically by hypoxemia, hypercarbia, increased intrathoracic pressures, which cause increased pulmonary vascular resistance, which is especially dangerous in patients who have pulmonary arterial hypertension. If severe, you can also sometimes see elevated hemidiaphragms in chest X-ray. So this anecdotal evidence has been shown by a few studies over the past 10 to 20 years. This is a study from 2010 showing that after component separation, we don't really have much change in the diaphragmatic position, but we do have a significant increase in abdominal volume. And hernia volume in univariate and multivariate logistic regression in this study from 2017 caused an increase in the odds ratio of pulmonary complications following hernia repair of approximately 1.5. Similarly, both lung and chest wall compliance severely are decreased with peritoneal closure. And we have significant increases in and progressive increases in peak and plateau airway pressures. And this study from 2012 shows pretty dramatic increase in the odds ratio of severe post-op respiratory complications following abdominal wall reconstruction, with an odds ratio of 5, with just changes, increase in plateau pressure of 3, and increasing to an odds ratio of 11.5 with change in plateau pressure of greater or equal to 9. So much so that this author mentioned that in his institution, the patients with a plateau pressure of greater or equal to 6 following abdominal wall reconstruction are kept intubated for 24 hours postoperatively, and an increase in plateau pressure by more than 9 caused them to be intubated and paralyzed for 1 to 2 days postoperatively. Now, it's important to bear in mind that this postoperative intubation is not without its cost, as prolonged postoperative intubation itself is associated with an increase in odds ratio of postoperative pulmonary complications. Again, just to emphasize, you're only going to see these changes with peak and plateau pressures in patients who are on volume cycled mechanical ventilation. And this is the graph that I showed earlier. In the red box on the bottom left is what you'll see usually following abdominal closure, which is increase in both the peak and the plateau pressures. If someone's on pressure cycled mechanical ventilation, as mentioned, the peak and plateau pressures are approximately the same, since the ventilator alters volume based on the pressures that you choose. And so decrease rather in lung compliance is not going to cause a pressure alarm. It's just going to say that the tidal volume has not been achieved. Thank you for your attention. This is my reference, and please feel free to contact me in the email below if you have any further questions about anything I've said. Thank you.